interesting topic and very similar to the conversations that we just heard about neonatal neurotoxicity. We're going to walk away with very similar thought processes. In other words, we just don't have the answer yet. But that's kind of getting to things a little bit earlier than you might like. I have conflicts of interest. All of them have been declared by Mike, so I don't even have to say anything about them. The only one that conflicts with this particular talk is NIH funding. So I wanted to make sure that everyone in the room understands what we're talking about. And it's in essence postoperative cognitive dysfunction. But I added to it postoperative delirium. And the reason for that is when I walk around and talk to people, most people have no idea that those are two very distinct and separate entities. So we'll discuss that first. And then we're going to discuss the different types of outcomes that are associated with these two disorders, and then look at the evidence to suggest that anesthetics either are or are not precipitators of this event. So this is a very nice psychiatrist version of how you diagnose something. It's the American Psychiatric Association DSM-V criteria for the diagnosis of delirium. The things you'll notice that they think are important and I think are important are highlighted in red. There's a lot of verbiage here. The beautiful thing is that Sharon Inouye made it simpler for us by simply helping us to identify those people that are delirious based upon some very simple criteria. Now, it looks simple here. Actually doing it is significantly more difficult. But what you're looking for is an individual, and it can be either young or old, because if you have a large enough insult, even very young individuals can develop delirium. It's a change, and it seems to be acute in onset, and it fluctuates over the course of the day or over the course of a couple of days. Its hallmark is inattention, and you have to have both of those two things in order for somebody to have delirium. And then they either have to have some disorganized thinking. That could be things like I see elephants that are sitting on top of the room, or it could be talking about things that are completely unrelated to the types of things that you were just discussing with them. And then an altered level of consciousness, and most of us know the most prominent form in internal medicine, which is the hyperactive delirium. That's the patient that's screaming, yelling that somebody's going to kill them, pulling out their IVs. But in the perioperative setting, it's actually the hypoactive delirium. That patient we all like because they lay in bed. When we go to do our rounds, they really don't respond to us. You get through rounds really, really quickly. But the reality is that the outcomes from both the hyperactive form and the hypoactive form are very similar. Why did I bring delirium up here? Well, A, the question is whether or not anesthetics have a role, but even more importantly, it's not just this acute, short-acting event that's the issue. It's really the fact that it leads to significant increases in morbidity and mortality. Some of them are listed here. The one that you really can't deny is the mortality. That's kind of a terminal event. It's very well defined. And even there's a significant risk of either 30-day, 5-year, and 10-year mortality associated with the development of delirium. And it costs us a lot of healthcare dollars. That's very different from postoperative cognitive dysfunction. Most of you know that the international study on postoperative cognitive dysfunction was published in the late 1990s, and it was a research classification. There's no DSM-IV criteria. There's no ICD-10 codes for that at the current point in time. And what it requires is a change in preoperative to postoperative, very carefully administered, roughly an hour and a half neuropsychometric tests. The problem with POCD, and it probably really does occur, but we don't have any uniform ways of identifying it, and the criteria might have a huge impact on what it is, whether or not you diagnose someone or label someone with postoperative cognitive dysfunction. This has led to an effort in the POCD world to try to come up with consensus with regards to how you define POCD as well as the nomenclature around that. And you'll see over the course of the next couple of months a number of publications coming out to describe that nomenclature in a variety of journals. This is a study that was done by Dr. Rasmussen, who was a part of the international study on postoperative cognitive dysfunction. And what you can see is that there are a number of different ways to look at or diagnose postoperative cognitive dysfunction. And depending upon how you look at it, even at what would be the third test or 3 months after what would have been an incident death event of postoperative of surgery or anesthesia, you can see that roughly 16.5% could have POCD, 25% could have POCD, or absolutely none, depending upon the criteria that you use. So when you read this literature and it says this percentage has POCD and it's way outside the box, you have to stand back and say to yourself, is this real? What I didn't tell you in the beginning is that all of this data was actually run on the control group, those individuals who did not have surgery and anesthesia. And we know that from the international study on POCD, which is the criterion that's used here, somewhere in the 3 to 4% range have some deterioration in their cognitive performance. All the same individuals looked at in a different manner, so I'd be careful when I read them. These are the results of what Derry Monk and the International Group on Postoperative Cognitive Dysfunction found. And what you see here on the left-hand side is the international group, and what they found, no surprise, regardless as to how old you are, in the first week after you have surgery and anesthesia, your cognitive performance isn't all that great. This makes a lot of sense to me. I have a cold and I don't feel very well. I'm not thinking at the top of my game, and if I have the flu, I'm not going to be thinking for a couple of weeks. What's more interesting, though, is that when you look 3 months out, you'll notice that there's roughly a 10% prevalence of postoperative cognitive dysfunction in the older individuals, and it's only 5% in the younger. This compares to roughly a 4% decrement, or 3 to 4% in those who did not have surgery and anesthesia, suggesting that there's something about this perioperative period, the surgery and anesthetic, that led to long-term cognitive impairment. This study over here is Terry Monk's, and she found something that's very similar. So I was young and impressionable when these studies came out. Wow, how does this happen? And I work with somebody who was an attending anesthesiologist, as Stu knows, at the Mass General at the time, and when you'd walk into the room, there would be skull and crossbones on top of your vaporizer. Kind of an odd thing to think about, but that was the reality of my life. And so we ultimately started looking at whether or not anesthetics were involved. And part of the reason for that is that POCD, just like delirium, is associated with a very significant amount of morbidity and mortality. It increases your impairments and activities of daily living. Those are the very basic things that really old people like to make sure they can do. Can you feed yourself? Can you bathe yourself? Can you toilet yourself? Your life changes a lot if you can't do each of those. Premature loss from the workforce. And then once again, the ultimate outcome, which is an increase in mortality. So when we decided to take this to the lab, and I really was naive, we thought that we would look at anesthesia, which is great because no one had ever done that before. But when you sit back and think about it now, what an idiot I was. For the previous 40 years, people had been calling anesthetics neuroprotective agents. A lot of animal data never was translated into human data, and that's where this story's kind of going. I would argue that rodents are not humans, some humans may be rodents, and so we did a number of studies where we were looking at rodents and the effects of a general anesthetic on their cognitive performance. We did all sorts of very fun things. We measured their temperature, we measured their blood pressure, we measured their blood gas, we made sure that we measured their inhalational anesthetic concentrations, and we were trying to do this really, really well. It's really hard to do that. It's exhausting. To answer that question, and what we found in a couple of studies that were published in 2004 is that if you're an old Fisher 344 rat, and I'm going to be very explicit, the only one that I worked with was those Fishers, although other people have repeated this, you can find that when they're tested beginning 2 weeks after anesthesia for trial number 1, that the control animals make more correct choices before they make an error when compared to the anesthetized animals. Now, Tim, I love you, but you're hitting at my soul because the number of animals that are here is really, really small. Even I had to say to myself, is this luck or did it happen? We repeated it a couple of times. But there was a 4-year interval before another single person published something similar. And I'll tell you what, when you're the investigator, you're sitting back there and saying, I must have gotten this wrong. Well, there was an additional study. This is by Rod Eckenhoff's group, and what they did is they took wild-type animals and animals who had beta-amyloid abnormalities. They were transgenic mice, and they anesthetized them either with halothane, isoflurane, or a control group that didn't receive either. And what you can see is that in the control group and the halothane group, now who would have thought that halothane would win out over isoflurane? There was no differences in their performance. But when you looked at those animals that had received the isoflurane, there was marked differences. Different type of testing modality, similar type of finding. Since that point in time, there have been hundreds of papers that have looked at this. We have significantly contributed to that literature. Some of the things that had happened during that point in time, though, that I found to be very interesting and gets back to what you said, was this idea that Rod Eckenhoff and us, we both did the same gene array. And interestingly enough, the genes we reported on were not the same. They were different. There was a little bit of overlap, which makes you sit back and say to yourself, is this real? Did we do it the right way? We did what we thought was the right thing, 2 different groups, 2 different outcomes. It's unlikely that either were the case. There have been thousands of papers written on POCD, tons of behavioral papers to demonstrate that in either Fisher 344 rats, other type of old rats, and I think it's important to recognize that this is an older person phenomena rather than a younger person phenomena, they had cognitive deficits after a simple anesthetic of a couple of hours. There are a number of potential mechanisms that have been identified. Neurodegenerative diseases. Does it exacerbate Alzheimer's disease by increasing amyloid beta or tau? Neuroinflammation is a very interesting one because, yes, general anesthetics in an old animal increase the inflammatory cytokines and the inflammatory cascades. But when you compare the increase in neuroinflammation as a result of our anesthetics to the inflammation you see as a result of surgery, you can't even put them on the same graph and find the anesthesia effect. There's also some studies that have looked at the blood-brain barrier disruption that can occur, synapse loss, and as both Drs. Eckenhoff and our group have done, the proteomics and genomics have all been used. And there are a number of potential therapeutic modalities that have been suggested, tons of them. But the clinical data suggests something different. It aches my heart to say this, but it goes back to the idea that there's either some flaw in what we're doing with the animals, or because they don't have surgery, we're not necessarily seeing an effect of anesthesia because the surgical effect is so great. This is a study that looked at general versus spinal anesthesia and postoperative delirium. It gets down to, does it matter what we give the patients? And what you can see is that for delirium, if you've got 497 patients in the regional group and 929 in the general anesthesia group, this is a meta-analysis of a number of studies, you don't really see any difference in the prevalence of delirium. Oh yeah, that number looks smaller, but when you do the stats, it just doesn't come out. In other words, it would suggest that spinal versus general doesn't make a difference. Well, I sit back and I look at that and I say to myself, well, this is really great information, except for one thing. At our institution, and it's a lovely institution, if you give a regional anesthetic, it is combined with a propofol drip, and often a jaw thrust from the resident who doesn't want to be bothered by having to speak to the patient during the course of the surgical procedure. So I wasn't necessarily too beat up by that one. But then we keep coming up with more and more of these. General versus spinal anesthesia and postoperative delirium. This is high-risk surgical procedures, 54 versus 50%. You'll notice that these numbers are not nearly as large as the numbers that Andrew was talking about, and we're not seeing anything. So we don't know. Does it cause postoperative delirium? Certainly isn't looking like it to me. The next question becomes whether or not it's associated with postoperative cognitive dysfunction. Once again, regional anesthesia versus general anesthesia, relatively small study. This is a study that was done by the same group using the same methodology as the international studies on postoperative cognitive dysfunction. And there's a trend for it to be different here, but they're absolutely the same here unless you want to call a very small difference statistically significant, which this was not. There's another study that was recently done by Brendan Selbert and his group from Australia, and they found something even more interesting. They randomized their patients to general anesthesia versus regional anesthesia for ERCP, and they had to terminate the trial because the regional anesthesia group had a higher prevalence of POCD when compared to the general anesthesia group. So very similar to what Andrew had mentioned, it makes it a little difficult to understand where this field actually is at the current point in time, and whether or not we've done all of our studies in an appropriate manner. This is the other type of thing that I see people doing. Gosh, you know, this really makes it look like Xenon is a superior drug. Well, yeah, that could be, except for these two were done by Terry Monk and her group, at a different place, at a different institution. And I don't know what their education level is at either of those institutions, but I know at our institution it's way higher than where I grew up. This is at a different institution, and some people have been known to compare those together. Yep, that could well be, if you've got enough patients involved, be a statistically significant difference. But I don't think I would be fooled by the idea that that's any different than the others until they were all run together. The other problem that you'll see in the literature is, what is this POCD thing that we're talking about? Is it short term? Is it long term? Well, anything that happens in the first week happens to everybody. It doesn't necessarily persist. It can in a very small number of individuals. But this is a study that was very recently published that looked at, in 50 patients, the risk of POCD in those treated with isoflurane, propofol, and sevoflurane. They're calling it POCD, and it is some cognitive deficit that's postoperative, but this is in postoperative day 3, at a period in time when they're still in the hospital likely, and otherwise having the effects of their surgical procedure. There's hope in the future. Mark Newman was one of our former residents at the Brigham and Women's Hospital, and he is involved in a very large, multi-centered trial trying to investigate whether or not regional anesthesia is a predictor for postoperative delirium, or whether or not general anesthesia is a risk factor for postoperative delirium. The data aren't in. They're having a hard time enrolling patients because the protocol requires that certain types of patients get in, and that eliminates most of our patients at the Brigham. So by definition, I would say that's a bad study design. Other people have looked at depth of anesthesia, and we've heard a lot of stuff about the BIS monitor, and originally it was used so that we could determine whether or not a patient was going to have awareness. I've used it frequently to try to convince the residents that they can turn down the volatile or anesthetic agents, or to slow down the infusion of propofol. But previously, I didn't think that it had much additional use other than that. When you look at BIS monitoring, there's something that's interesting about the old brain. It's very different. The EEG, if you speak to Emory Brown or read any of his stuff, the EEG response of the old brain to a general anesthetic is just not the same as a younger individual. This was a study that was done a long time ago in 2009. They took a whole bunch of different depth of anesthesia monitors and took young patients and older patients and gave them propofol to find out at what BIS value or what SED rate value or depth of anesthesia would the patient fall asleep. And it's interesting to note that all of these values were higher in the older patients when compared to the younger patients for whom the BIS analog of keep it between 40 and 60 was developed. In other words, that old brain is different. The question becomes, if that old brain is different, then doing something to the brain, does it have any effect? Because you're going to see these changes. So I have a colleague, his name is Fritz Sieber, and he is an interesting guy who left academics and went into private practice, but was still interested in the brain. And he noticed that in his group, a private practice group down near Hopkins, that you could take your colleague, and one colleague would have their BIS basically at 80, hardly any anesthetic on board for sedation with a regional anesthetic, and the other group would have a boatload of anesthetic on board and an average BIS value of 50, which I think is supposed to be a general anesthetic, and if really you're starting here, probably 50 is a little bit deeper than it would be in somebody who's younger. So he randomized a group of patients after he recognized this to either a BIS of 50 or a BIS of 80, and found that for those individuals who had the BIS of 50 or deeper levels of anesthetic, the likelihood of them developing delirium was higher than those that had the BIS of 80. The interesting point here is not even that. The doses of the anesthetic on average to the patients were the same. So it may well be that their differential response to the anesthetics with regards to the EEG and what the EEG sees is different. There have been a number of studies that have looked at this, and the data is pretty reasonable to suggest, this is work from Mike Avedon in one of his studies, to suggest that actually depth of anesthesia may be a predictor of postoperative delirium. In other words, those patients who are run more deep or have a brain that's more sensitive to the anesthetics may be at greatest risk for delirium. That'll be something we'll talk about on another day. There's a study that's being done at the current point in time by Mike and his group, and they're going to look at EEE guidance for anesthesia to alleviate geriatric syndromes, and one of those syndromes is postoperative delirium. So what about depth of anesthesia and postoperative cognitive dysfunction? Well, this is a study that was from that same international study group for postoperative cognitive dysfunction. And what they did is they took their median change in Z-score and their mean cerebral state index score, or a depth of anesthesia, and looked to see whether or not there was any correlation, and they found nothing. Can you draw a line through that for me? Is it like flat? Okay, I figured he might be able to do it in his sleep. So the information there isn't necessarily in, but there have been other groups that have described that depth of anesthesia monitoring in a randomized trial decreases the rate of postoperative delirium, but not postoperative cognitive dysfunction. Okay, that's good. But there are others that have suggested, this is another one that suggests that for BIS-guided versus BIS-blinded, the odds ratio here is 0.67. The p-value is 0.25. The number of patients is unbelievably small, but a piece of evidence that would suggest that even for POCD, that if you have BIS-guided anesthetic, you might have a better long-term outcome. So I'm hoping that this study by Paul Miles's group, where they're trying to look at and design a balanced anesthesia study where they're going to be doing BIS monitoring to look at a whole bunch of things, but the primary outcome is mortality. I'm hoping that as a part of this, it would suggest that they're going to at least look at postoperative delirium, and I'm hoping POCD, but I don't know that for sure. So you're probably sitting there saying, this woman didn't tell me anything today. And you're right, I didn't tell you anything today. Nothing that you don't know. Basically, the word is still out. I don't think we know whether or not the anesthetics have an effect, but I would argue that if they do, the effect of your surgical procedure is probably greater. So there's a couple of take-home messages, and those are that POCD and delirium are real. They're associated with significant morbidity and mortality. There's inconclusive evidence that regional anesthesia is better than general anesthesia, or that the anesthetics contribute in humans. There's a lot of data to suggest that they contribute to adverse cognitive outcomes in rodents, and that BIS-guided anesthesia may lead to decreases in delirium, but the data are still inconclusive with regards to POCD. And with that, I am actually giving Dr. Karish back 10 minutes. This is our lab, and I just have to always put this slide up because I would tell you that in order to be an investigator in current times, especially if you're trying to balance some sort of basic science and clinical science, requires a village, and this is the village that's raised me. Thank you.